easily identify your osteoarthritis, the first one can be a very minimalistic, which is not even visible in the radiological, or you can suspect few changes, which can be at the age of 40 plus or 50 plus. And then you can have the mild osteoarthritis, where you can see the cartilage damage, having few cracks here and there. And you can see that the cartilage involvement, if it is on the weight bearing area or at the other areas where the joint range of motion as it moves. So the mild, moderate, severe is involved. So this is how you can have these small spots. That means there is a mild form of cartilage damage happening. So this is not a very smooth, and you'll have to understand that this is like a ceramic bowl. So it is very smooth, and you can have these small spots which can indicate that there is a mild form of osteoarthritis. And generally the treatment can be a general exercise and try to reduce some weight so that the load is decreased. And when you look at moderate, you can see these are your osteophytes formation, which is a normal process of calcium degeneration and regeneration of the calcium and finding spots. So this can come into your articulating surface and cause damage to the cartilage further when you do a range of motion. So these osteophytes itself can cause damage to the cartilage. Along with this, if you have a meniscus problem where there is a degeneration of the meniscus, again with the age, the fluid content, everything is going down, then it can again allow the direct contact of the cartilage from the femur to the tibia and start the degeneration. Ideal treatment in these patients is to get to the weight loss, get some strengthening exercises. If the pain is very severe, you can use some pain relievers. You can also use a steroid injection. And then when it comes to the severe OA, there is a lot of erosion of the cartilage, particularly on the weight-bearing areas where it is probably grade 3 and grade 4, and the patient is severely physically disabled, where they might need a partial or a total knee replacement. I'm not going to touch upon the patellofemoral arthritis. Again, this is also got a cartilage, and it is part of your knee complex, where they can also have erosion depending upon malalignment of the knee and maltracking of the patella, which can lead to patellofemoral arthritis. And the other form of arthritis is your common rheumatoid arthritis. And rheumatoid arthritis, if you see our textbooks where we read about deformity, all those criterias of pain and all those things, now if you see the last 5 to 10 years, they are well managed, and you don't get to see people having very bad deformities until and unless they have not been treated in the right way from the early stages. So what is the problem with knee, and who tend to have these kind of arthritic problem? The primary structural change we are looking at is worn out of the cartilage. And this can be because they had rheumatoid arthritis, or they sustained an injury to the joint and it changed the biomechanics slightly and made the cartilage to worn out. Then you can have infection, which leads to the cartilage getting worn out, or it can be just your age-old process of getting old. And patients, what they can have is common is joint pains and stiffness. So when I say stiffness, patient tends to sometimes feel my joint is stiff. Bow legs and knock knees, these are structural abnormalities which can have the knee having a different weight bearing going on to the tibia. And this can lead to the degeneration of the cartilage at one particular angle. And this can lead to the quality of life. So they tend to say that I cannot walk more, I cannot climb the stairs. So they tend to make their change in their lifestyle. So this is the Osteoarthritis Research Society recommendations, and what they give you the guidelines for a non-surgical management of a knee osteoarthritis. The American Academy of Orthopedic Surgeons, what they generally recommend is exercises which can be land-based, water-based, and strength training, weight management. You can use electrotherapeutic modalities like TENS or EMG biofeedback for your exercises. They also recommend acupuncture or dry needling, braces, and wedged insoles. So this is the broad guidelines recommended by the American Society. So the use of EMG biofeedback acupuncture is in a question mark in their places, and the force and wedges, they don't generally say that it is very beneficial. Whereas if you come into the American College of Rheumatology, what they recommend is exercises, weight, acupuncture, and wedged insoles. They recommend that they can be used. So you can understand that there are two different groups in the medicine itself where they recommend in a different way. Now coming on to the European people, they again stick to saying exercise and weight management, whereas the braces, they say they are not sure, and the wedge insoles, again, they say that it is of not much help. The Osteoarthritis Research Society recommends a set of few tests. They say that this is the primary test what you can do for your osteoarthritis patient. Now, in osteoarthritis, the basic problem is based on the patient where their pain and function is going to be affected. Now, there is no gold standard assessment in the people with ONE. Unlike we have special tests for various conditions, the radiological X-ray what is used will give you an idea about how the osteoarthritis is there. One is that one. The other one, what they say is you have to use more of a performance-based test for the physical function. That means we can use those tests where we can assess the functional capacity of the patient. Now, this is the 6th test. It's a 30-second chair test. So you ask the patient to sit to stand for 30 seconds, stair climbing test. So you can have about 8 to 9 stairs. So this is going to assess all the problems what commonly patients tell. So this is a timed up and go test where a person is going to walk for a particular distance, 40 meter. So he will use his own pace and walk and come back. We check the time and see how he is. Now these tests, if the patient is in need of a walker or a stick, he will still use them and then do the walking. So the strength training or the recommended treatment by the Osteoarthritis Research Society is exercises, self-management and education, which is very important. People should know what it is. Then you should have weight loss. So what weight loss can do is a 5% of total body weight, which can reduce for a period of 20 weeks, will decrease at least the load that is going on to the decline. So what is the goals of the rehab? The basic goal of a physiotherapist when they are looking at an osteoarthritis patient is trying to maintain and improve mobility. So keep them as mobile as possible. Try to improve their strength. Maintain and improve the aerobic capacity of the patient. Improve the balance and coordination and the posture. Now, a lot of the time people ignore on the balance and coordination because they think that it is okay or it is not required. But it is very important because there is going to be change in the kinesthetic sensation and the proprioception that is going to come from the knee joint. So when you have a patient with a mild to moderate ONE, the recommended treatment for physiotherapy will be pain relief, exercise to maintain mobility, and weight loss, exercise and you can probably use a kneecap or a brace. Now, people with severe osteoarthritis, you can try with some pain modalities. Try to maintain the mobility as much as possible. Stick to a very good diet program. Give them a walking stick if required, and make the activity modification as much as possible. So coming on to the pain management, ultrasound can be used, even though there are not much evidence going to show. It can just probably help a little bit on the inflammatory process, and IFT can be a temporary relief to pain, so that you can help them do their exercises. Now, this is a combination of electrical stimulation or an IFT, what we use in this for my patient. So we use a wireless technology, which is basically a Faraday current, where I can use them to stimulate the muscle. So I'm targeting the VMO muscle to fire when they do the exercises, progressing it with weights. If the pain is very severe, I can use the IFT so that the pain is suppressed and still he can do the exercises. I do a lot of taping and needling also. So this can be used as a temporary measure for patients to see if they can, offload the patella and fire the muscles of the quadriceps a little bit more, so that there is some amount of pain relief and the patient can exercise. So these are X-rays where you can find patients having more of a bone-to-bone contact. So that means there is a lot of degeneration of the meniscus, which is getting the cartilage coming into contact. And this is a scanogram from the pelvis, which is going to measure the angle, which will show that the valgus angle or the varus angle is more. And based on that, you need to do the surgical correction. So coming on to the exercise therapy, what is the basic recommendation is, when you have a knee OA without comorbidities, you can use medicines, exercises. So this is a flow chart which will recommend what kind of medication and modifications you need to do. Now, the important thing what we need to understand here is the core treatment appropriate for all the individuals is basically exercise and strength training. It is only the medications that keeps changing in the different groups with or without comorbidities. So the role of physiotherapy becomes very important, how we plan and give the exercises. So the land-based exercises, in this study, when they look with people with comorbidities and other morbidities, they say that they tend to have a very good score in improving their function. So remember the first 6 tests what we look. So the patient's arthritic changes is not going to change, but they become more mobile. And they found that Tai Chi and strength training with range of motion, these kind of elements tends to help more. And they found that there are studies which have shown that Tai Chi is a form of exercise which gives better results. Coming on to the strength training, both weight-bearing and non-weight-bearing exercises. So when I say weight-bearing exercises, it can be a simple squat. But when do you start, and when you start an open kinematic exercises will plan and produce results for your ONE patients. Coming for the water-based exercises, what they say is they have very minor benefit for pain and generally recommended for patients who are obese and have severe pain. You can start on water-based exercise and then slowly progress to the land-based exercises. So this is Tai Chi, where people stand in a particular pose, and this is more of a low impact strength and flexibility which is concentrated. You can also correlate this with yoga, where we can do an yoga based on low impact and flexibility. And when you do the required asanas, then you can improve strength and stability. So again, this is yoga as per modified. So you need to modify them based on the osteoarthritis. This is something what I always emphasize people on their exercise program, that whenever you in mind, first is verbal command. So what kind of a command you're going to give? Vision, whether the person is going to have a spotter. That means somebody is going to see him and tell him, okay, this is how you need to keep your feet. This is how you need to move. This is your foot position. Contralateral limb, always also treat the opposite limb, and you can take that as a reference to help him improve on that. Sensory input is very important because with age, people can have diabetic, they can have altered sensation, and this all can change the proprioception and balance for the patient. So you need to be prepared to modify any form of exercises for them based on the age. So it can be, one is the osteoarthritis itself, and then the age what they have and what is their goal. That it could be that I find it difficult to get up off the chair. You need to have a good assessment of your manual muscle testing, and you should have a good understanding of the biomechanics. Your physiology is also very required because you're going to have aerobic capacity which needs to improve. Always understand that if you're going to give a low load exercise, there's not going to be any benefit. A very high load is going to be a risk. So you need to find your optimum load which will be benefited, and then you need to progressively load. So that means if I'm going to give this patient a quadriceps exercise, you should know that you can't just start with 1 kg, 2 kg, but you need to start with 5 kg, 10 kg and progressively keep increasing them. So before you start a program, have your design. Make sure you are planning how much frequency you're going to give, when you are going to progress, what is the intensity you're going to do, what type of exercise you're going to do. And every program is going to be individualized for that particular person. Sarcopenia. It is simply nothing but loss of skeletal muscle mass with aging. So as people age, people will lose muscle mass. That will in turn allow them to lose the strength of the muscle. A lot of the time in clinical practice, we see patients thinking that, okay, I have a degeneration of my knee joint. So if I do exercise, will the knee get even more worse? No, we are trying to gain the muscle what people are losing, so that half the load is going on to the muscle and not to the knee joint. And how can you improve this muscle? Not only by exercise, you need to have good nutrition, maybe have some supplements, and then trying to be as active as possible. Before you plan your exercise, understand isometric exercises can be used for pain relief and for muscle activation. That means you're understanding that the muscle is actually functioning. Isotonic exercises are going to be more strength-based and functional. Closed chain exercises will have more load, more functional, and incorporated as a progression. Open chain exercise can be during the initial phase, and it can have a decreased load on the joint. Progress to multi-joint exercise program where you are going to have various joints getting loaded. Progression has to be based on the load, not on the repetition. And progression has to be based on function also. Manual muscle testing, always first check whether the muscle activation is there or not. Then check the muscle strength both in concentric, eccentric and in the middle range. Check the muscle strength of the hip muscles, knee muscles and the foot muscles. Common tightness you can find for patients is on the iliopsoas, quadriceps, hamstrings and calf. This is a common exercise possibilities we have for our patients here in ONE. And these are all the exercises we will not give, but based on the assessment, we will be using some of the exercises. So coming on to the single component of muscle strength, we are going to look for identifying the weakness and the tightness that is available in the muscles. Check for muscle activation, check for the strength, isolate the muscle in all the ranges, the initial range, mid-range and the last range. Try to work on hip muscle, knee muscles and the foot muscles. all the muscles have to be checked and strengthened. Isometrics, everybody knows. I would like to give you a hint or a tip here. Never tell the patient to press the knee down. Most of the times, patient try to press the knee down using the hamstrings or the gastroc rather than the quadriceps. The best one will be have a visible palpation on the hand, touch it, and then ask them to just contract the muscle so that the patella moves. So that will give you a clear indication that they are doing the isometric quadriceps. Exercise has to be difficult. At least they need 3 weeks a session, and it should be at least 45 minutes of exercise. Periodical stretching has to be done. Associated problems of diabetes, hypertension, these things has to be taken into consideration and modified based on that. Now, this is earlier what I showed, that how we use a modality and get the activation done. Water-based exercise, again, remember, is recommended when there is severe pain and the patient is obese in the initial phase. So you can tell the patient that this is just going to be a short-term one, and you can progress their activities in the aquatic area and then move to the land-based area. The other thing is patient gain confidence that I can do these movements without pain in the water. The muscle is going to function far more better. There's going to be less exercise-induced pain, less weight bearing, and then you can strengthen the muscle and then go on to the land-based. We prefer using the resistance band for all the patients with OA depending upon their pain capacity. So these are your hip strengthening, your side SLR for the glute medius and the glute maximus. So we are using the band at below knee, and we will progress it based on how they progress. This is VMO strengthening along with the adductors, which is going to facilitate better firing of the VMO. So this is a combined way where he's doing an isometric adduction and doing a isotonic extension. Progressing to the closed kinematic chain exercise, supported squats, and then going on to sit to stand. So this is my progressive loading for the patient. Now, if I find the abductors are weak, then you add a band and add the abductors with the squats and progress, or for the appropriate patient, add adduction with squats so the VMO gets to fire more. Calf stretch is one of very good exercises you can use for your patients with OA initially to relieve pain. You can you have to understand that the posterior capsule tends to go tight with people who are having osteoarthritis, and that will in turn allow the calf also to be very tight. So this is a standing calf stretch, and this is a prone knee hangs where you put a towel just above the thigh, allow the weight to go. You can also add a weight over here to allow the stretch to come. Walking versus cycling. Again, walking is going to have your weight bearing going on to the knee, whereas cycling will be more of mobility. So this is more a safe exercises. So you can see that this is a simple exercising gadget which a person can use at home and just get that mobility maintained, because if the mobility is maintained, there's going to be good amount of fluid moving and nourishment happening over there. This is not going to improve your osteoarthritis, but help you maintain it. This is a recommended cycle what the patient can use, or even the outdoor cycling. Weight loss, go on a diet program and work on the weight loss, because there is going to be a 5% decrease in the load that goes onto your knee joint every time you lose weight. Knee caps and braces are available. There is no proper or good evidence for the effect of knee cap. I generally don't recommend knee caps for patients with OA. The only thing they give is a feel of something holding onto the knee. But what this will do is it will avoid the proprioception for the muscles to recruit, and that will not help them in getting the work done. Just a second. Hello. Yes. So this is the kneecap. Now coming on to the braces, these are unloading braces. Okay, now these are working on a 3-4 principle, 3-point principle. So when you have a joint space decreasing, these kind of braces, which are slightly expensive, can take off some amount of load. But these braces has to be worn whenever the patient is going to do activity on weight bearing. The footwear modification that is recommended in some of the orthopedic community is the wedge. So you can see here how there is a raised wedge here. So what can this do? Just like the principle of the brace, when you raise the wedge on one side, it is going to alter the weight bearing load on the medial joint line. So it can give you some amount of load off on the knee joint, which the patient will be able to have some pain relief. Walking aids, walker or a tripod or even a walking stick is good. But the problem what we find generally is patient try is not willing to use. He feels that I don't want to be using a walking stick. So it needs a lot of counseling to the patient to tell that it is good and it is right and it is not bad to use a walking aid and do. There are recommended injections for patients with osteoarthritis. But again, remember in the first slide what I said, in grade 1, grade 2, they can help. Again, the evidence is very altered. Some say good, some might not help. But it is an intra-articular injection which is done. And along with this, still you need your weight reduction and physiotherapy to be done. Surgeries, you have unilateral compartment where it is alone replaced, or you have osteotomy done over here. So what they do is, instead of replacing that, they cut, make a wedge, allow the joint space to increase. So you can see that in this, there is an increased space. So you do a osteotomy over here, wedge osteotomy, and then increase the space over there. The other one, what everybody knows, is your total knee replacement, where you replace the articulating surface with a metallic or metal ceramic components. So what will happen if patient will have an untreated arthritis? A lot of the time people have their own assumption and their own ideas, thinking that no, I can manage it. Very untreated. You can see this one, how it is bone on bone and the angle is so bad. So post-surgery, these are corrected in the angle and then replaced. Then the patient is able to walk. So you can see how bad they are. So this is how pre-op a patient is there, and post-TKR, his quality of life is improved. So this is ignored patient developing such a bad arthritic changes and realigning and getting them back into mobility. So this is a patient of TKR who did not follow up a proper rehab, ended up having an FFD after 1 month. So the patient was again taken up to general anesthesia. Again, the leg was straightened. And this is, you can see now with the exercise and other thing, he is now again back into keeping it straight. And now he is following up the exercises properly. So there are some of the myths and facts, what I would like to highlight here. People tend to think that I should stop exercising after pain relief. No, exercise is also one of the pain relieving factor, and it is more about improving your mobility and progressing to muscular strength. So encourage the patient to keep exercising at least 3 to 4 days a week. Exercise will damage the knee. This is a misconception a lot of the public have. So explain them that it is not going to damage, whereas it is going to help them improve the muscle strength. But only thing is they need to have a correct dose of exercise, and correct method. Cannot be going on walking, telling that exercise, I am walking and it is an exercise. No. Kneecap will help in pain relief. It is not possible. Some people, it can give them a temporary pain relief and give them a confidence. But we see a lot of the time people have this kneecap telling that if I have the kneecap, I feel I can walk. But that is again not to be used regularly. I should continue with the medication as long as possible. No, medications are not curable. They are not a long-term thing until and unless it is a calcium. Alternative therapies, a lot of the time people try to have some form of alternative therapy where they have heard. Till date, there is no cure for advanced osteoarthritis knee. Everything can give them a temporary relief. If a patient goes with a knee replacement, they feel that it might take months to recover or they might not. If the surgical procedure is done in the right way and the proper rehab is done, they can have the best results. So the take-home message is osteoarthritis needs a multi-model. Physiotherapist alone is not going to help. You need to educate the patient that if it is a very painful knee, yes, an injection can help them come out of the pain so that your exercise can be better. Only in the late stages, you need surgery. But if you come in the early stages, you can prevent your surgeries. As and when braces or orthotics or walking devices, you need to find whether which patient will need. Based on then you give, put them on a weight loss program and give them a lot of education about their problem and call them for a review once in 3 months so that you know how their progression is going on. Plan for water-based exercise in whatever way you can do, which can help them in pain, mobility, and strength in the initial phase if they are very badly disabled. Progress to land-based exercise. And remember, land-based exercise has to be strength and functional always. Always check for the muscle activation and follow it with a proper training program. Assessment is the key to plan your rehab. So your assessment can be your recommendation of those functional tests, which can be a better way of approaching an osteoarthritis rather than using only a radiological X-ray alone. And weight reduction, if you think the patient, has to be mandatory for these patients. So that's my grandmother who never required a TKR in her life and just the stick and she was all rocking. So that's about the OA knee, what I would like to share with you. If there is an option with questions, you can ask me questions. Okay, there is a question.
Sir, we having one question, sir.
Yes, sir.
Sir, that one person asking from the chat box, how medicine can work inside the knee joint if there is no blood or nerve supply?
Yeah. So it is basically absorption from the fluid. Okay, it's not everything in our body is not going to go through the blood. Okay, it is fluids. You have this fluids, how it moves from one area to the other area. That is osmosis. So you have those, that is how you are going to expect some changes, which is going to carry to the joint. Now, again, remember when I said medication and other things, it is not going to change anything on the cartilage or anything. It's basically your pain relief, which doesn't have to go into the knee joint. And when you are looking at calcium also, it is not going to go to the knee joint and go into the calcium is not going to get deposited. It's going to be a systemic one. And that is how it is going to get corrected. Is the injection a procedure done? No, injection is not done by physiotherapist. It is done by a trained orthopedic surgeon.
Excuse me, sir. I had one question. Can I ask?
Yes, ma'am.
Yeah. So I wanted to ask the injection which you were talking about. So does it have that any kind of steroidal effect like on the contralateral side, like that which we use for the shoulder also? So if the patients do take shoulder injection in the form of steroids, so they have a chance of developing frozen shoulder in the future. So even that has the same effect on the knee joint also?
See, the injection, what I mentioned, is more of a lubrication. It is not a steroid.
Okay.
So it is basically just trying to have them some form of lubrication, which can help the joint be little more supple. That's all. For the shoulder, what they do for pain is more of a steroid-based injection to relieve the pain.
Okay. Thank you.
Okay. There's a question on Tai Chi exercise. Tai Chi is a very subtle form of exercise. You can check on the internet how it is done. Okay, it's a very simple low load. It is slow movements, but again, you use the basic biomechanic principles of doing a sagittal plane, frontal plane, flexion, extension. It is done in weight bearing. You can do whatever range you can. You move the muscle very slow. So you allow the muscle to lengthen actively and shorten. So that is how what the research says is they are very good for osteoarthritic patients. Sir, okay, there's a question. How can we advise for walking for OA&E patients? Okay, OA&E patients, again, depends upon what I generally do is if I know the grade 2 or grade 3 is there, I tell these patients maybe walk twice a day. But initially, if I find strength and other things are poor, I tell them to start doing their exercises first, get some strength component in, then I allow them to do walking only maybe for about half an hour or maybe 1 kilometer. Other days, keep it to cycling so that the aerobic capacity is also taken care of. Plus, they can enjoy their walking. So you balance your walking and cycling in terms of your aerobic exercise. And as well as brace around her knee in order to prevent her pain, sir. What will be the protocol relief pain? Okay, this is a very vague question, but with the hernia and other things, I would like to know how much weight she has, plus what is the strength, okay, and what kind of OA, whether she's medial joint alone or generalized with patellofemoral also coming into play. She's using a spiked stocking, so I'm assuming she has got varicose or it is just the swelling they are looking at. But initially, I will just put her on a basic strength training program. If she cannot do with the resistance band, I will start with simple SLR and all these kind of exercises. Try to check the calf stretch for these patients, because if the patient has been using stockings for a long time, she can have some amount of tightness. So you can look at 10 days to 15 days to relieve the pain for this patient. But in the meantime, also progressing the exercises, telling the patient that she can do the exercises because you have to come from pain to strength. So that will start helping her. Is it always indicated to carry out provocative test structures involved? When you have OA&E, we are not going to look at anything of provocative there. But with OA&E patients, and if you are suspecting a ligament or those kind of things, if the patient has got very severe pain, you can't do a test, because if the test is going to be again causing you pain, you don't know whether the pain is coming because of your test or the existing pain. So you need to take some history into account, the radiological test, and maybe do your structural provocative test later on when the pain settles. How quadriceps angle will help for our knee rehab? Okay, I am not sure whether it's a quadriceps angle or a Q angle, but I will just try to answer that one. When you have a externally rotated hip, or people who walk with a external rotation, so what you are doing is you are not using your normal kinematic or kinetic line when you walk, which muscle has to be loaded. These times, patients might tend to use more of the iliopsoas and ignore, the adductors, and the VMO might tend to less contribute when you walk. So when you teach your patient gait training, also we want them to see that when they walk, they have appropriate amount of quadriceps firing in. So that is the reason why your quadriceps angle is very important when you exercise. And remember, sarcopenia, I said if you have wasting of the muscles, your muscles can be in a slightly altered position. So that is why in one of the videos and picture I showed how you have your adductors functioning and then you do your quadriceps so that you can get a better recruitment of the quadriceps. There's another question, which technique is better on OA? Closed kinematic chain versus tissue flossing. Tissue flossing can maybe help just to allow the recruitment or control the pain initially. But overall understand, even with tissue flossing, your closed kinematic chain exercise is mandatory. I will prefer the closed kinematic because functionally our knee joint is more closed kinematic rather than open kinematic. So I will prefer closed kinematic chain. When manipulation techniques useful for grades in OA knee, if you're looking at grade 1, grade 2, yes, they can be of some help into the pain. But again, this is not the best technique probably for OA knee when the patient is having pain, because when you try to mobilize even at grade 1 and grade 2, you can get the pain triggering factor coming from the capsules or any of the ligament. So a simple isometric is also good enough to get the pain relief done. I'm not required to use manual techniques for my OA knee patients. If the patient is having grade 3 and having stiffness on the knee, again, manipulation is not going to help because it is still going back to that stiffness, and the grade 3 will still stay the same. Emphasize the role of physiotherapists following knee replacement or other surgeries. You need to know the previous pre-op status of the patient. If the patient has been walking with a sway before the TKR, like in one of the videos, so you understand that the patient's muscle function has been completely different. So once the correction is done, make sure that your muscle function is also appropriately corrected. Only then you are going to get your optimal result functionally. So as a physiotherapist, you should be doing your pre-op assessment and post-op assessment, and your periodical assessment has to be proper. Sir, no, and only knee joints. Why says cat? I could not understand that question. So, is that about the questions?
Yes, sir. Yes, sir. Yeah.
Okay, sir, knee joint, if fluid present, then remove fluid can helpful OA knee patients. No, you don't remove the fluid from the knee joint. That is called aspiration. That is done only in case of hematoma going into the knee joint, or you have any other fluid inside where you want to know what kind of fluid it is, whether there is infection. Only then you remove the fluids. Protocol for total knee replacement. Different surgeons have their own protocols, but you can always suggest them if there is appropriately something has to be changed. Now, we follow a particular protocol, but it is not that every time we stick to just the protocol. There, it is more of a guidelines. Sometimes we make alterations in the patients. Sometimes we have a patient who's done a TKR done, but he has got a very bad flat feet or a unilateral pronation. So then our protocol slightly varies for these patients. So you just need to have your guidelines, have your open mind, and stick to the basics as much as possible. Okay, can you tell me which is better in OA rehab, functional electrical stimulation or neuromuscular electrical stimulation? I will use functional electrical stimulation more because if my muscle tends to recruit better, the functional capacity improves. That can in turn change the proprioception and other things. So that is the way I look at it. What are the sequences of muscles affected in knee joint? My principle is anytime you have a knee joint, always first go for the hip. Because if you look at the physiology of the muscle, the hip muscle tends to shut down as much as possible. So that's your gluteus maximus, which will be the primary one, and the gluteus medius. Because those two muscles, when they under fire or alternately fire, they tend to change your biomechanics of the knee joint. Knee swelling, what are the treatments can be given in knee rehab? Again, swelling, suprapatellar, infrapatellar, intraarticular, those kind comes. But anytime you have swelling, okay, fine. One is if it's very acute, where you get to see the patient within the first half an hour, go with cryo, ankle pumps and all those things. This will allow the swelling to come down. If you have a injury-based swelling, then maybe you can have your ultrasound based on how you understand ultrasound, and you can use them. I also use taping for the acute inflamed knee joints. Is there any specific symptoms on patellofemoral and tibiofemoral condition? Maybe symptomatic if the patient is just standing and they can have pain, some walking pain. Patellofemoral, you can probably find their angle. There they will say when I try to bend my knee, whether it's open kinematic or closed kinematic, maybe around that 15, 20 degree or 30 degree angle, where they come in contact with the trochlear groove, where they have pain, then can indicate a patellofemoral arthritic problem. And you will need radiologically a skyline view of the X-ray, which can again give you indications on them. Thank you. Pain caused by much reduced in joint space as revealed by X-ray. How do physiotherapists help? I have also seen patients where their grade of OA knee was grade 4. That means the knee is bone on bone and the patient did not complain of pain. Now, the pain signs, you need to go back and read a little bit on pain signs, how the nociceptives are reacting and how the chronic pain works. Now, for the patients who are having a very bad joint space, you can probably offload the joint by giving them a cane and asking them to do a partial weight bearing maybe for 2 weeks, because by that time the load which goes to the knee joint and triggers the pain mechanism can be offloaded, and you can work on some amount of mobility and then progress. Along with this, you can also use TENS, which might help them. And once your exercises comes back, then you can look at long term. But if it is a very bad reduced joint space, I think surgical intervention is the best option what the patient should look at.
Thank you so much, sir. This was a knowledgeable session. It gave some deep insights into the topic and also revealed some interesting information, sir. Thank you so much. Now, I invite Dr. Saranraj sir, Professor, Department of Orthopedics, Nandha College of Physiotherapy, to deliver vote of thanks.
Thank you. So I'm very glad to give vote of thanks for all. First of all, I thank God for successfully completing this webinar. Next, I thank our resource person, Dr. Ganeshan sir, for his very busy schedule. He gave us time. It was wonderful and very knowledgeable webinar, sir. Thank you, sir. Next, I thank Dr. V. Manivanan sir, Principal, Nandha College of Physiotherapy, for his excellent support and new thought of ideas to give knowledge to all. Next, I thank our Ortho department team members and Gopal sir for his enormous support. And next, I thank all the HODs, staffs from other department. Finally, I thank all the participants. Thank you all.
Thank you, sir.
Thank you, team, for a well-coordinated one. And it's always pleasure from the Nandha College group. What I have seen in the years, how Nandha has been taking the academic thing. So keep up the good work.
Thank you very much, sir.
Thank you, sir. And I thank you for spending this time in this pandemic to share your knowledge with us, sir. Thank you. But not the least, I thank everyone for your patience throughout this webinar and those who extend their hands and supported us and made this webinar a successful one. Thank you, everyone. Let's wrap up and meet up in another session.
Thank you.
Thank you, sir.